Today we are going to discuss the last part of it, that is the heart failure management, a comprehensive clinical guide to management of heart failure. So far we have discussed in the first part the pathophysiology, the definitions of heart failure. In the second part, of course, management was all in all throughout the course. The second part we discussed about how you diagnose heart failure, where we discussed about the biomarkers and echocardiography. And then we went on to a very special discussion last time for a particular topic called heart failure with preserved ejection fraction. Today, we're going to see heart failure in general from a management perspective. We already done the diagnosis, the evaluation, other things. So now we'll be focusing solely on management. So there were certain pending issues which we wanted to discuss, which we'll be discussing today. Now, today, very excited to have with us Dr. Niraj Yadav. Now, the thing is that we kept him for last for a particular reason. Now, if you played any games in your childhood or even now, maybe you all know that the final boss is the one, is the one who's the most kind of powerful, knowledgeable. So we kept Dr. Niraj Yadav for the end, right? So he's the final boss of heart failure. Also a personal friend of mine. He's a electrophysiologist and a cardiologist from Zydus Hospital, Ahmedabad. He has been serving patients, cardiac patients, for the last 2 decades. His areas of expertise include cardiac electrophysiology, RF ablation, 3D mapping, cardiac pacing, cardiac resynchronization therapy, defib implantation, even the regular coronary interventions also, but he's specialized in EP studies. But particularly, and that is somewhere, I think, from his own origin story, which Dr. Niraj Yadav once told me, that his primary interest started with heart failure, and that is where evolved into. So that's an interesting thing. So I think when we thought about the heart failure series, the first person who came to my mind was Dr. Niraj Yadav. He said, we are going to have him, and then we'll plan out all the entire series around him. Niraj Yadav, we can't see you, but welcome. Now we can see you now.
Yeah.
Yes.
Thank you, Dr.
Welcome.
Om, for that introduction, and I'm really looking forward to it.
Yeah. Just before we start, your journey with heart failure. You once told me the story that heart failure was something you were very interested in when you took up cardiology. So your interest in heart failure, per se.
Yeah.
Because this is, you trust me, this is the era of heart failure. This is where, so I think 2020s are where heart failure is really taken off in terms of both the discussion and knowledge in both cardiology and other fields as well.
Yeah. So heart failure is interesting in a way that if you have any coronary or any cardiac problem, the moment you acquire the cardiac disease, you are already in heart failure.
Right.
And so we'll not try to categorize heart failure only in a symptomatic stage. So there is a lot of opportunity even in a pre-symptomatic phase of heart failure to create a difference in patients, not only the quality of life, but survival. And especially when we have more therapeutic options available. When we look heart failure not as a problem of heart only, it gives an immense opportunity to collaborate with different specialties to create a real impact in patients' life. So I always wanted to do heart failure fellowship after cardiology, and then somehow I entered into electrophysiology, which again gives an enough opportunity to treat patients with heart failure. So yeah,
great.
So that.
Absolutely. Just to introduce you to our series, which we have been doing, we had these 4 parts where we took the collaborative approach and look at heart failure, mainly from a diabetic patient perspective. And right now we are in the section where we are going to discuss a bit of management. Now, we had some management discussed earlier, and there were certain controversies. So like I said, you are the final boss. So you'll be unrevealing a lot of these controversies. We have put a lot of these controversies for you in the end. So a few things, not major. I think we all agreed, our audience agreed on a lot of things, but there are a couple of issues which, as we come along, we'll seek your opinion on this. Okay. So this is going to be a discussion. Please feel free to put in your comments at any point. And again, to the audience, please ask your questions in the chat. Please don't raise your hand for now. In the end, we'll allow you to raise your hand and ask the questions live to Dr. Niraj Yadav. So you all saw this earlier, the heart failure classification. This is the 4th time we are dealing with this. And this is generally the first slide we always start with. So you have heart failure with reduced ejection fraction, which is LVEF less than 40%. Heart failure with the mildly reduced ejection fraction or mid-range ejection fraction, which is 41 to 49%. The heart failure with preserved ejection fraction when you have the LVEF more than 50%. And then the new term, which is heart failure with improved ejection fraction, when you had a LVEF of less than 40, which improved to more than 40%. Now, interestingly, if you see the discussion we had last time with Dr. Arindam Pandey, he told us something very interesting and very important, that these are all different entities. Do not see them always as a spectrum. These are different entities in itself. And a heart failure with preserved ejection fraction is not necessarily heart failure with an improved ejection fraction. So somebody who's come from a HFpEF and goes on to improve the ejection fraction is different from somebody who just had heart failure with preserved ejection fraction. Dr. Niraj Yadav, what's your opinion, especially for this new entity, which is HFpEF, which is heart failure with improved ejection fraction? What do we really understand with that?
Yeah. So first of all, this slide it reminds us that heart failure does not mean any particular ejection fraction. It can occur with any ejection fraction. So it is wrong when you are thinking about heart failure, you are always thinking about a reduced ejection fraction and echo.
Right.
Second thing, even if heart failure is not associated with ejection fraction, still we would like to classify it based on ejection fraction, because on basis of that, our therapeutic strategy is dependent on.
Right.
So these are two things that one should always remember. Second, the question regarding improved ejection fraction, these are the patients who previously had reduced ejection fraction, and with medications, current medicines or guideline directed medical treatment, they have now shown improvement in ejection fraction. Now, this is again very important subset of patients to recognize, where you have seen the benefits of heart failure therapy. And many times error is on when ejection fraction improves, patient always insists that, okay, I'm fine now. Why don't you stop medicines? And these are the subgroup of patients where you should not stop medicine. This is a group of patients where therapeutic success is proven, and that means that you should continue it, because stopping of treatment in this group of patients will often come with relapse. So this is again an important subgroup of patients.
Excellent. So I think this is again a theme which we have learned from the earlier talks as well, that if you have a patient with heart failure with improved ejection fraction, I think the take home message is absolutely that you should not be stopping the treatment, right? You should not take the foot off the gas. You should not keep the accelerator on. It does not mean that the patient has improved for life. It means that the patient has improved, patient is responding to treatment, and that means that the patient needs to continue the treatment. So I think that's a very important message again for the audience listening to this, that when you have a patient with an improved ejection fraction, it's a good sign. It's a good news, but doesn't mean that we stop the medication. We continue the medicines and we continue. We had discussed the role of NT-proBNP. So just to reiterate, especially for heart failure with reduced ejection fraction, and NT-proBNP has a very important role in ruling out heart failure. So when you have a normal heart failure, of course, with the caveats, some of the obese people tend to have a slightly lower NT-proBNP. So again, you need to interpret everything in the light of the overall clinical situation. But NT-proBNP is useful to rule out heart failure. So that's one very important use case. And again, rule in heart failure when the levels are particularly high, which we had discussed in the earlier lecture. But now let's come to the 4 essential pillars of heart failure with reduced ejection fraction, right? So we'll first discuss the HFrEF category, and then you have the 4 essential drugs which are part of the therapy. So you have RAS inhibition, you have beta blockers, you have SGLT2 inhibitors, and you have MR antagonists. So Dr. Niraj Yadav, sir, these are now very well established 4 pillars in management of heart failure. So what are your views on these medications, and generally how do you really use them in your HFrEF patients who come to you in an OPD basis and a chronic outpatient basis?
Whenever you look at heart failure with reduced ejection fraction patient, the goal of treatment is to start this guideline directed medical treatment as early as possible to give optimal benefit. These 4 group of drugs have shown in multiple clinical trials, there is a very robust evidence that these drugs not only improve the heart failure symptoms, hospitalization, but also increases the survival significantly.
Right.
Whenever given a chance, if patient tolerates, start all these drugs together, start at least with lower dose and titrate it according to the patient's tolerance and clinical benefit. If patient's clinical profile does not allow simultaneous onset of these four drugs, then it is a prudent option to start according to the patient's clinical presentation, one, two, and then gradually build up the other group of drugs.
Okay, this area of, what you said, simultaneous versus sequential, whenever possible, try to start all of them as early as possible, put all the four on board for treatment. I think this came from the school of thought that a lot of these patients are actually have a very low survival rate. And if you do not start all the possible therapies which have proven improvement in terms of benefit, in terms of the mortality risk reduction, then you might end up with a patient who dies before he's given all the four therapies. So that's what happens. And so right now the guidelines are very clear that you should try and start all of these with the target range of treatment within 3 months of the onset of diagnosis. And then of course you'll require frequent monitoring. But sir, in practical sense, when you start the patients on multiple medications, the patient also has this little bit of pushback from the patient also. Secondly, there could be certain volumetric connotations of starting a lot of these medications together. In practice, of these four, which are the ones which you start early on, and then which are the ones you add on after maybe a couple of weeks or maybe a month? So what's your general take on terms of the preference of amongst these four drugs?
Yeah, so again, it depends a lot on what clinical profile patient has come in. So if
Right.
patient has come with congestive cardiac failure, obviously you are going to give them diuretics, but along with that, you are going to give SGLT2 inhibitors. If they are tachycardic, you are going to add beta blockers. If patient has come with hypertension, heart failure, you are going to add RAS inhibition, preferably with ARNI. It's very important to categorize this patient, whether what pathophysiology or is predominantly acting on in developing heart failure in that particular patient. My way of looking at this patient is if patient comes with a decompensated stage of heart failure and preserved hemodynamics, I would like to give diuretics to give them symptomatic benefit, but at the same time, I would like to add SGLT2 inhibitors and ARNI and beta blockers first. And after that, I also add mineralocorticoid receptor antagonist if patient is tolerating all these three medicines. If patient has come with hypotensive heart failure, obviously the RAS inhibition comes secondary, but you try to add SGLT2 inhibitors, low dose beta blockers, and mineralocorticoid receptor antagonists first, because these are going to be easily tolerated in a patient who has borderline blood pressure or hemodynamics. So there is no one right answer. Some people start the drugs as the evidence had come up, like AC inhibitor or RAS inhibition first, then beta blockers, then mineralocorticoid, and last comes the SGLT2 inhibitor. So that approach is also fine, but yeah, so there's no
So I
one
think
right answer. Yeah,
so I think maybe case by case basis is what
a
would
lot
be
depends on the
how the
patient's
clinical presentation of.
presentation. Yeah.
Okay, absolutely. And within what period of time would, in a typical, let's say, a hypertensive, congestive heart failure patient, in what period of time would you like to onboard all the four drugs? So maybe 2 months, 3 months. What's your time frame generally? When what
So
kind of?
majority of heart failure patients would then be discharged with all four medicines. But yes, there are going to be patients where you have to introduce them sequentially.
Right.
And when you are going to introduce them sequentially, the aim is to have all four group or four pillars within 3 months of initiating the or starting this treatment. The reason is that not only these four drugs are important in reducing heart failure status as well as improving survival together, but also the benefit is independent of each other. Each and every drug is going to contribute to improvement in prognosis of this patient. So it is very important to have all four drugs in heart failure patients.
Absolutely. Great points. Looking at the ARNI now. So ARNI has been a game changer in a lot of ways in terms of especially heart failure with reduced ejection fraction. I think it's probably a very important drug which has shown significant survival benefit, and it comes from neprilysin inhibition. So I think we already discussed in the first lecture about pathophysiology some important learnings which we had from earlier also, that if your patient is on an ARNI, you require good potassium monitoring, which is very important. Also, secondly, don't use BNP because the BNP values can actually increase initially when you start the patient on ARNI. So again, it would be better to use NT-proBNP when you're monitoring patients on ARNI. And again, the key trial here is the Paradigm HF trial, which showed 20% reduction in the cardiovascular death or heart failure hospitalization versus enalapril alone. So I think that is where the sacubitril/valsartan had an advantage over the thing. And so one side effect you have to really watch for is, apart from monitoring the potassium, is that you'll watch for angioedema. So what is the typical dose regime that you start a patient on ARNI? And again, from your perspective, what are the things you monitor when your patient is started on an ARNI?
Yeah, so ARNI is a very important group of drug in heart failure with reduced EF, especially when it has shown 20% reduction in CV death and heart failure hospitalization over enalapril. There's no point of giving preference to AC inhibitor or ARB over ARNI. Always ARNI first when you are considering RAS blocking. Second thing, always start with a low dose of ARNI, because when you're starting the ARNI, you don't know how the patient respond to that. So there are good chances that your elderly, frail patient or ARNI can develop significant postural hypotension and come up with a episode of syncope involved. So it is very important when you are initiating this medicine to look at the blood pressure response, not only just supine blood pressure, but always look at the postural blood pressure drop when you're initiating this. And second is rise in creatinine and potassium level. Particularly when we are talking about diabetic patients, they often have diabetic nephropathy. They have presented with decompensation, so a good dose of diuretic is given. You have to look at the renal function changes. You have to look at the potassium level. So start with low. 50 milligram twice a day is the recommended dose in majority of the patients with heart failure. But we often encounter a patient who first time comes with a very advanced stage of heart failure. Their blood pressure is significantly low. And in those patients, we rather start half tablet twice a day, which I know is not a recommended dose, but we have seen that this works well. And when they come up in follow-up, we could increase the dose to 50 milligram twice a day and then build up on that dose in follow-up. So yeah, always start low, go gradually and monitor these parameters, postural drop, potassium and creatinine in these patients.
Absolutely. So I think it's a great point. So great practical point for the audience. So I think even though the starting dose recommended is 50 milligram twice a day, in certain patients, probably you can start half PD of 50 milligram, that is 25 milligram half PD. So it's how you started. And the target ultimately being trying to build up over 200 milligram BD, but again, depending on how the patient is responding to therapy and also the side effect profile of the patient. And I think postural fall is something which is very common. Patients experience the symptoms, and I think that should be looked at when you're dealing with these patients. And one more side effect, which is actually not much known, but I think that needs to be understood as well, that these drugs also reduce blood sugar. So we have seen episodes of patients developing hypoglycemia, but not because of ARNI alone, but these are often diabetic patients who may be on a sulfonylurea or insulin, and sometimes introducing ARNI can lead to patients going into hypoglycemia. These are all vulnerable patients. Again, some of these patients may have a slightly elevated creatinine or a diabetic nephropathy. So I think that's another thing which you should be looking for when you have a patient on ARNI, especially those with very tight glycemic control or vulnerable to hypoglycemia, especially older patients. Be a little careful when you're starting ARNI, and probably consider titrating the dose of the anti-diabetic drug also. So I think that's something which is important. And if you see the Pioneer HF trial, they actually started these drugs during hospitalization also. So you can start at the time of discharge or close to discharge as well. Now, beta blockers, sir, and there has been a lot of controversy in this segment also. So we had a couple of cardiologists who were earlier in this program who were very clear that beta blockers are a life-saving medication for heart failure with reduced ejection fraction, but they were of the opinion that in heart failure with preserved ejection fraction, as such, the guidelines also do not recommend a beta blocker, but there might be, in fact, potentiality of some harm. So, what's your take on beta blockers? I'm sure it's a cornerstone of heart failure management, at least HFpEF management for years together. But what's your view on beta blockers in heart failure with preserved ejection fraction? Because that's been an area of little controversy and little pushback from the audience also at points of time. So, what's the role of beta blockers per se in heart failure, and amongst that, the subset of patients with HFpEF?
Yeah. So heart failure, again, there is no doubt that it's beta blocker is a wonderful drug, and it has got the 35% of survival benefit in heart failure reduced ejection fraction.
Right.
But majority of heart failure medicines, if we look at, has not worked very well in heart failure with preserved ejection fraction, and beta blocker is again one of them. There are candidates in heart failure with preserved ejection fraction also who are going to benefit from beta blocker. But yes, these are the patients who have increased sympathetic tone, which you will assess when these patients come. They are often having heart rate on higher side, blood pressure on higher side. You given all the drugs, and beta blockers is going to help in this patient. Patient who have atrial fibrillation, which is very common in heart failure with preserved ejection fraction. And especially when you want to control rate in atrial fibrillation, the beta blocker often becomes the first choice of therapy in such patient. It is not the drug for heart failure with preserved ejection fraction in general, but even in those patients, there are certain subset of patients where you would like to give beta blockers.
Absolutely. So I
Survival
think
benefit, yeah,
this, yeah.
survival benefit cannot be claimed, even though, but yes, you would like to reduce the patient's symptoms. You would like to, so in those patients, you have definite role of beta blockers.
Right. So I think it's a great answer. So I think to the dear audience, I think what we can say is, what we can conclude from this four-part series from Dr. Niraj Yadav is that, of course, heart failure with reduced ejection fraction, there's no doubt you will have beta blocker as a cornerstone of therapy and one of the four pillars. But HFpEF, use it judiciously, use it for specific indications when you have those. But again, you might not have a mortality benefit as far as HFpEF. Again, so you need to be a little careful as far as the use of beta blocker in HFpEF is concerned, but HFpEF, I think there should be no reason. I think we'll glide over ACE inhibitor and ARB because I think it's very clear right now that amongst the RAS inhibition, maybe ARNI should get a preference, but ARB also, in case for any reason ARNI cannot be given, ARB also has its own role in the management of heart failure. But now let's come to a very interesting group of drug, which we have discussed this earlier also, but we'd like the view of Dr. Niraj Yadav sir on this, especially about Findenon. So you have mineralocorticoid receptor antagonists, again, becomes a very important group of drug. So let me, sir, first ask you this rookie question. If your patient already has some amount of RAS blockade with your ARNIs and with your ACE inhibitors and ARBs, why do I still need to block the RAS pathway further down the line with the MRA?
If you look at the pathophysiology of heart failure, there is the link of survival benefit is with RAS blockade and mineralocorticoid receptor antagonist. Aldosterone antagonism is very important, and the one of the reason why these drugs have shown a benefit in improving survival is because of its anti-fibrotic effects.
Right.
Fibrosis in the myocardium again is going to be the reason why these patients are more prone to ventricular arrhythmias. It has shown improvement in survival. Also, there is obviously some diuretic effect which may give some symptomatic benefit, but most importantly, it is a very important group of drug in a patients with reduced ejection fraction, studied in less than 35% of ejection fraction, but we still would like to give in a patient who is borderline reduced like 40% of ejection fraction. It has very robust data of reducing ventricular arrhythmias, sudden cardiac death in patients who have heart failure with reduced ER.
So I think that's a great hat you put on from an electrophysiology perspective, that the cardiac remodeling is prevented. I think so. Despite giving RAS blockade in other ways, it independently has its own benefit as far as the cardiac remodeling is concerned. Am I correct in your interpretation?
Yes.
Okay. And what's your view on now you have emerging data with Finrenon? So now you have Finrenon where you are looking at a non-steroidal MRA, which has lesser side effects in terms of does not produce hypotension, maybe that you consider the side effect, does not have severe hyperkalemia as you have with these agents, and though mild hyperkalemia can happen, and at the same time does continue to have benefits. So what's your view on Finrenon right now in terms of use in heart failure?
Still, the MRAs like spironolactone and eplerenone remains the choice of drug.
Right.
I would rather start spironolactone in each and every patient because not all patients are going to have some side effects like gynecomastia.
Right.
Eplerenone is clearly expensive drug than spironolactone. Those patients who develop this side effect, they are switched on to eplerenone. And Finerenone, in my practice, is reserved for those patients who have significant hyperkalemia with spironolactone or eplerenone because of some data that hyperkalemia is lesser as compared to these two drugs. So those are the subgroup of patients because heart failure evidence is maximum in if you are using for heart failure, then obviously the data of spironolactone is much better than Finerenone. But diabetic nephropathy, your intention is more to preserve the renal function, avoid hyperkalemia. In those patients, probably, and you have seen that these patients are developing hyperkalemia with MRAs, then Finerenone can be used.
Absolutely. So I think that's again a great point. And again, what I understood from a lot of these trials as well is that, again, if you have HFpEF, I think it's a no-brainer. Probably your eplerenone and spironolactone does tend to get a sort of heads up, unless there are, of course, other reasons, like you said. But if you have a HFpEF, they had some data with the Finart study with the Finrenon. But again, having said that, what I think the earlier cardiologists also were of the opinion that unfortunately the original studies, spironolactone in especially TopCat study, and they were done for these patients, especially, there were a lot of heterogeneity in the study done for HFpEF, and that's why the evidence was not very robust. So probably, I think you look at, and last time Dr. Arindam Pandey said that I would still probably, even for HFpEF, also consider spironolactone, even though the Finrenon has more robust data. Again, in terms of cost also, Finrenon tends to be more expensive. So there are, again, practical considerations also. So maybe, but again, having said that, I think the important message is that MRAs should be part of the heart failure management. Now let's come to, again, a very important final boss in heart failure management, SGLT2 inhibitors. Now, it's remarkable where where we started with SGLT2 and where we ended it. So I still remember, and let me tell this anecdote to the audience. There was once a long time back. This is before the data for SGLT2 started coming for heart failure. SGLT2 was a pure anti-diabetic drug when it first came. And Dr. Niraj Yadav once sent me a patient, obese lady, where we actually initially suspecting Cushing's, right? But turned out had just basically morbid obesity. And she had heart failure. And at that point of time, she was pre-diabetic. So thought, okay, we didn't have too many drugs. Patient was not ready for, so GLP-1 was available, but again, GLP-1 used for obesity that time was also off-label, and patient was not ready for an injectable. So that was the first patient where we intuitively started the patient on an SGLT2 inhibitor, and the patient did remarkably well. And then the data started emerging in terms of heart failure use as well. SGLT2 inhibitors really started as an anti-diabetic drug. Now, I think probably if you say in terms of the clear mortality benefit and clear use benefit, I think it's now a primarily drug for heart failure and becomes the diabetes part becomes more of a secondary. So your views on SGLT2 inhibitors, especially empagliflozin, which is now emerging as a very important class of drugs amongst the SGLT2 also. And just again for the audience to remember, the cardiologist dose for empagliflozin is 10 milligram, right? So whether you're using a DEPA or an EMPA, probably you'll be using 10 milligram for both of them from a cardiology perspective. So Dr. Niraj Yadav, your opinion on SGLT2 in heart failure?
As rightly said by you, SGLT2 inhibitor is revolutionary treatment while for management of heart failure. If you look at the spectrum of heart failure, where SGLT2 benefits is no other drug has worked in all spectrum of heart failure as SGLT2.
Yes.
Obviously, it has to be included in all heart failure patients where it is indicated or where it can be tolerated and given. I have not seen any drug which has data of increasing inotropy of heart with without increasing ventricular arrhythmia. So
Right.
all of the drugs, all of the medicines, be it digoxin, dopamine, anything, PD inhibitors, everything, if milrinone, they all increase the inotropy, but they increase the calcium overload of the myocardial cells and they increase the ventricular arrhythmia and increase surrender. Even though it improves the temporary symptoms, you cannot give it for a long-term management
Right.
of heart failure. This is the only drug which has shown it increases the inotropy and it reduces the ventricular arrhythmia. So it is amazing. Now heart failure, more and more we recognize heart failure. We know that it's also an equally important metabolic problem. And
Right.
this is the drug which is going to improve cardiac energetics through metabolic pathways. It has got some diuretic effects, so it has also symptomatic benefit in patients who are having volume overload. And again, it has got anti-fibrotic and improved cardiac remodeling effect. So it's a wonderful drug, and it has to be used in almost all patients. The most important part when we were looking at SGLT2 in initial days, we were thinking that okay, we have an answer for diabetic patients in diabetic heart failure, but we never knew that it will be as good as a drug of heart failure in non-diabetic. So that is one wonderful property of this drug.
Absolutely. So I think a great point, I think for the audience, I think this is an absolute take home message that improving the cardiac ionotropy without increasing the risk of arrhythmia, in fact, reducing the risk of arrhythmia, because there are
Yeah.
studies where they've shown reduced risk of AF with use of SGLT2. So I think that's a great, again, take home because all the other drugs. So this is one paradox of SGLT2 comes with a lot of paradoxes in that sense. It's a completely unique molecule in a sense of way. And I think that's another thing, another very interesting clinical paradox. Again, if you would have seen in terms of we think of it as a mild diuretic, but unlike the other diuretics, whenever you use, there is actually a volume depletion, which with a lot of diuretics, where you have the diuretic effect, you have the third space volume reduction, but you do not have actual volume loss that happens, significant volume loss that happens. So I think that's another little bit of a paradox with SGLT2. So it's a diuretic which does its job without producing a significant volume loss. So it's again that becomes a good way of looking at SGLT2. I think, sir, mark my words on this. GLP is the next SGLT2, right? It's been around. I think GLP was there even before SGLT2. But the point is, I think it's getting a new lease of life now. And now there's a lot of interest in GLP. Actually, there's a lot of pharmaceutical interest in GLP. I think the SGLT2 has reached its peak. It has peaked, no doubt, right? The next emperor of diabetes and metabolic and probably heart failure management also is GLP-1 RA. Now, there is an emerging data with the STEP HFpEF trial, which was again looked at these data, summit data. So these are all emerging data, especially now they're looking more of untested territory, that is more of HFpEF, because the vision is that GLP-1 could be the cornerstone of HFpEF management. But if you see, probably in a broader sense, it would be effective in patients with HFrEF also. But I think primarily they're looking at GLP-1 RA right now as a probably a drug of choice. And maybe, trust me, in 5 years down the line, when you have the new guidelines somewhere for HFpEF, just like SGLT2 right, currently is class 1 indication for HFpEF and also class 1 indication for HFrEF, GLP-1 RA will become a class 1 indication eventually for HFpEF also. So with the more data which is going to come in this range. So, sir, your initial views on GLP-1 RA in as a cardiologist, right? Forget heart failure. GLP-1 RA, especially the newer ones like the semaglutide and tirzepatide. What's your initial view on this group of drugs?
Yeah. So again, heart failure preserved ejection fraction till now, we just used to manage these patients only on symptomatic basis. So if
Right.
patient has congestion, we try to reduce congestion. If patient has arrhythmia, we try to treat arrhythmias like atrial fibrillation. If patient has accelerated hypertension, control blood pressure, control diabetes. So these were the only thing, and we didn't knew whether these interventions are really going to increase the adverse outcomes in long term, because
Right.
what you're doing is eventually just managing their symptoms and just managing what is seen abnormal. But now increasing evidence with SGLT2 and obviously GLP-1 receptor agonist is again showing some benefits in heart failure with preserved ejection fraction, obesity in obese patients. And obesity is again a very complex problem, especially when it comes with heart failure. The management of heart failure becomes extremely difficult. And it's not just the management of congestion or management of hemodynamics, but you have to look at multiple things. You have to rule out sleep apnea, you have to manage their nighttime ventilation, you have to even reduce the weight. And reducing weight is an important parameter for men, making them feel better in,
Right.
from the point of heart failure symptoms. And there is a drug now which can do that. So obviously, I have no doubt that there will be symptomatic benefit in all the obese patients, be it heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. How it translates into the long-term outcomes, that
Right.
only time will tell.
Yes, absolutely. So it's a key point here. And again, very interestingly, tirzepatide right now is the only drug which has got a US FDA label approval for obstructive sleep apnea, which is very interesting. There's no drug on for OSA. The only one which got an approval so far is tirzepatide. And very interestingly, semaglutide, they are now going to get a label approval for intermittent claudication in patients with peripheral arterial disease. So I think these drugs are going beyond its use in obesity and diabetes. Again, used to be anti-diabetics, which has become anti-obesity drugs. Now they are primarily a pan-metabolic group of drugs. So I think there's an emerging area, the future king. A few of the other drugs and a lot of interest in some of them, especially Versigouat, right? Now, not a lot of people beyond cardiologists know about Versigouat. Any experience with that, and what's your view on? I think there's one trial, Victoria trial, which was the predominantly
Yeah.
studied. Yeah.
So it has been claimed as a fifth pillar, emerging fifth pillar of heart failure medicine, heart failure therapy. It is primarily used in reduced ejection fraction, but I also don't have much enough experience of this drug because we have only used in those patients who presents with decompensation of heart failure with all the four pillars that has been prescribed. So there are very few patients who where we have scope of giving this therapy. Also, it is a much better tolerated drug. So when you want to give some vasodilators and you can't give ARNI or other vasodilator drugs, probably you would like to give this drug. So patients with borderline hemodynamics, it's safe to give in renal dysfunction. So these are some group of patients where you have no other options to give drugs. Versiguat is an important molecule. Also, patient who comes with decompensation and you want to add fifth drug, then Versiguat is an option.
Right. So I think it's like you said, reserved for patients with HFpEF who do not respond despite the four pillars of management. And I
Yes.
think, sir, this one question which was there probably from an audience last time, ivabradine. Is there any role of that? Because we are always taught as non-cardiologists that ivabradine you use in patients where you want to reduce the heart rate, but do not want to produce hypotension or where you have the blood pressure on the lower end. Any role of ivabradine in heart failure management as of now?
Yeah. So rather than a heart rate reducing drug, it should be seen as a drug for heart failure, reduced ejection fraction, and patients with angina. So these are again like very Vericiguat, a specific group of patients where you have not achieved good heart rate control despite giving optimal dose of beta blockers,
Right.
or you could not give optimal dose of beta blocker because it was not hemodynamically tolerated. So
Right.
these are the specific patients where you would like to give ivabradine. But again, it's not the way we are talking about four pillars that you should give all four medicines irrespective of the profile. It's not the Vericiguat true with Vericiguat, or there are
Right.
specific group of patients where
Very
there is
good.
definite role of those medicines.
Okay. And again, correction of anemia what must be considered in all heart failure patients. And there are, of course, some studies where they looked at maybe injectable iron therapy even in those not having anemia. So I think it's an emerging area, but it's an area of a lot of controversy. But if the patient is anemic, for sure, correction of anemia does benefit the patient. Now, coming to your area of core expertise, what's the role of devices in heart failure, and where do you use them? When should we refer a patient with heart failure to Dr. Niraj Yadav for a device? What's the indication for that?
Heart failure patients not only have limited quality of life, but they have reduced survival. And
Right,
one of the reason of reduced survival in this patient is sudden cardiac arrest
right,
because of
right,
ventricular arrhythmias.
right.
The only therapy probably that has shown to reduce sudden cardiac arrest, obviously with all this wonderful class of drugs, there is some reduction with the drugs, but still there are patients where reduced ejection fraction, particularly ischemic heart disease, where there is a damaged, scarred myocardium. These patients are going to have ventricular arrhythmias, and ICD or defibrillator therapy is very important when ejection fraction is less than 35. Also, in patients where non ischemic heart disease is there, and these patients, particularly when there are clinical indications like unexplained syncope or documented ventricular arrhythmias or imaging suggestive of high risk of ventricular arrhythmias like cardiac MR showing high in areas of late gadolinium enhancement or fibrosis. These patients again are at risk of sudden cardiac death, and these patients should also be referred for ICD implantation. So
Right.
these are primary prevention patients. Obviously, all those patients have who have had VT episode and have survived and have reduced ejection fraction, they are candidate for secondary prevention of ventricular arrhythmia. But another important therapy in heart failure patient is cardiac resynchronization therapy, and this is indicated in patients who have reduced ejection fraction and delay activation of left ventricle, which is evident by the widening of QRS complex in ECG,
Right.
particularly left bundle branch block. So if you have a left bundle branch block and reduced ejection fraction, these patients have delayed LV activation and it produces adverse LV remodeling and reduced and worsening of heart failure. So if you advise them CRT, in CRT, what is done is that you implant leads in right atrium, right ventricle, and left ventricle. And this LV pacing will reduce that LV delay, improve the synchronization between two ventricles, and improve the ejection fraction. CRT is probably the most studied cardiac intervention over a period of decades, and it has the very robust data for improving heart failure ejection fraction in these patients. These are two devices therapies. Almost 30% of heart failure with reduced ejection fraction has some indication of cardiac resynchronization therapy. Not all of them, but yes, 30% of them.
Okay. Okay, great. So I think that's a great point. And of course, end of the day, heart transplant for patients with end stage cardiac disease in a sense. So that coming to a bit of, we had discussed HFpEF in great detail last time. So I just reiterate what we discussed last time with Dr. Arindam Parde. Again, for HFpEF, right? So when you have a preserved ejection fraction, again, it's a different entity. You need to see it in a different light. SGLT2 inhibitor is class 1 indication for this group. Also, first line therapy has to be SGLT2 inhibitors. Some of the other drugs like MRAs, and especially in MRA, Findranon has evidence. So this is where Findranon gets a little bit of boost up in terms of its use. Again, the other drugs, Dr. Pandey was talking about loop diuretic last time, especially if the patient is volume overloaded. So that's the thing. And again, beta blockers probably, unless there is indication otherwise, will probably not give beta blockers. But if you have other indications to give it, then you should consider HFpEF. Again, especially patients who are obese, GLP-1 RA has a very important role to play also. And I think, like I said, GLP-1 RA will emerge as a very important group of drug in future when you talk about HFpEF. So, sir, your opinion on HFpEF, your opinion per se on entity called HFpEF. I think HFpEF is a modern entity. I think it was there for a long time. We all knew that, but we never talked about it. But now, since we have therapies available, we do talk about it and we do consider looking at these patients more closely. So what's your view on HFpEF per se and the therapies for that?
Yeah, so when we are talking about HFpEF, I'm talking about in general heart failure preserved ejection fraction because there are some specific pathologies
Correct.
also which is
Correct.
going to produce heart failure preserved ejection fraction. We are not going to talk about that.
Correct.
So in general, heart failure preserved ejection fraction is, if you look at these patients, they are more likely hypertensive, diabetic, obese,
Yes.
female patients, elderly. So these are the patients who are going to have heart failure preserved ejection fraction. And many of times the symptoms takes the importance in managing these
Right.
patients rather than survival. Like reduce ejection fraction, we always think about survival.
Long-term survival. Yes.
Obviously, symptom reduction is very important, but long. So heart failure preserved ejection fraction, you are going to treat them with blood pressure if there is accelerated hypertension. That is going to make them feel better. You're
Right.
going to give diuretics if they
Right.
are congested. You're going to maintain the normal rhythm because in heart failure with preserved ejection fraction, it is very important to have synchronized atrial and ventricular contraction. So, if the synchrony is gone, if atrial contribution is gone by atrial arrhythmias, atrial fibrillation, which is going to be there in this patient.
Right.
So, importance of rhythm management is there. Patient who has other correctable cause like anemia, you have to give importance to
Those
anemia
as
in the subgroup of
well. Right.
patients. So you have to try and find out as much contributing factor to patients' heart failure symptoms and correct them. But now, apart from this, we have at least in obesity, we have GLP-1 RAs and SGLT2 inhibitors in almost all these patients of HFpEF, where we can have some 18% reduction in CV death and
Mm.
worsening heart failure is an important endpoint with SGLT2 inhibitor in heart failure preserved ejection fraction. So,
Right.
apart from this management of contributing factors of heart failure preserved ejection fraction, and there comes the physician's role. Every patient is different. You have to do all the things and then prescribe the proven therapy which in clinical trials. Also, mid-range ejection fraction, mildly reduced ejection fraction, there is some benefit of ARNI. You can
Right.
use that.
Yes.
MRAs in Finrenon has some promise as you told in fine arts, HF trial. Diuretics are mainly for symptomatic benefit, and
Correct.
I have seen that diuretics are when they come in decompensated phase, diuretics are given and they continue for long term. There's
Mm.
no point of giving diuretics for long term if patient is asymptomatic because
Correct.
many times patient when come in follow up they're completely dry, still
Mm.
diuretic is going on, creatinine is increasing borderline. Then this patient do not tolerate the very important drugs like SGLT2 or ARNI because of diuretics. And the first thing that you do is stop the diuretics if patient is feeling better.
Great. So I think these are great points. I think all of them, and I think they have a lot of risk of AF as well, sir. Atrial fibrillation
Yeah.
also. So
Yes.
these are the patients who tend to have
Rhythm management is
rhythm
very,
management is quite vital for these group of
yeah.
patients also. So that's again very important. Finally, acute decompensated heart failure. You have these patients come in the emergency or come sometimes in your outpatient also. We have decompensated heart failure. So any words of wisdom for these patients who will end up in ICU or ICCU? What do you 1, 2, 3 for acute decompensated heart failure?
So whenever patient comes with acute emergency,
Hmm.
there is always some trigger and there
Hmm.
is substrate.
Absolutely.
So if you have a patient coming with emergency, the most important part is start symptomatic management, start ventilatory care, hemodynamic management, depending on
Hmm.
the patient's presentation.
Hmm.
And then you look into the trigger events. What has led the patient to come all of a sudden in here? And
Right.
that question has to be answered. Whether
Hmm.
patient who was completely stable till now has any event that has led to decompensation.
Hmm.
And Champit mnemonics is written in the slide, and that is very useful mnemonics. Patient who had acute ischemia, or patient has accelerated hypertension, patient developed any arrhythmia. These are very important triggers for developing decompensation heart failure. Patient has undiagnosed infection. I would give one example. A patient had recently only, a patient had a decompensated heart failure. There is already a substrate. Patient had reduced ejection fraction, but he used to be a very compensated phase with all four important drugs. And he came with decompensated heart failure, and nothing could be, we didn't know why he presented with decompensation. And during rounds, when we dig deeper, he told that there was some pain around perianal region. And when we examined, there was a large perianal abscess. So the abscess was a trigger for his decompensation. And you have to specifically look for this, because patient may not tell. He may feel that it is not
Not
important
related. Yeah.
for his breathlessness.
Yeah.
So these are very important things to look at, and these things should be taken care of. There is no amount of drug or anything is going to settle his heart failure if you have not taken care of that abscess. So immediate drainage would settle his heart failure without adjusting too much of medicine of heart failure in this case. So assessment of triggers is very important. And second, once patient is stabilized, then it is very important that by the time of discharge, patients are on all guideline directed medical treatment. So these are, and always try to reduce unnecessary drugs in heart failure patients, because these patients are elderly. There are a lot of drug interaction happening. And many times what we see is, because of some unnecessary drugs, you have to stop a very important drug. And so these things are to be taken care of in a decompensated stage of heart failure.
Great. So I think it's a great lesson altogether. I think these are, of course, a few special cases, and of course, diabetes. We already, I think now a lot of heart failure management is aligned with diabetes management per se. So I think that is same with CKD also and elderly also, to be very careful. And I think polypharmacy is a very important thing. A lot of unnecessary drugs. Look at the indication for each of these drugs and see whether they continue to have a role in that particular patient or not. And if not, then probably consider stopping it, because patients collect, just like they keep seeing different doctors, they keep collecting medications and prescriptions. You often see patients with a long list of medications, and there'll be three different types of diuretics given by different people. So a lot of times we have things getting combined with a lot of specialities being also involved. So I think that's something which we need to be aware of. And of course, drug interactions also contribute to the same. Okay. Again, if you see overall as a practical guide, the goal-directed medical therapy, you start with your ARNIs, beta blockers, MRAs, SGLT2s. These are the first week where you can start all of these drugs wherever possible. And then you gradually up titrate this doses depending on the monitoring and the preference of the patient, and of course the clinical direction of the patient. So these are the ways in which you manage these patients. And of course, common things you always look for is hyperkalemia. A lot of these drugs produce hyperkalemia, hypotension. Interestingly, if you see, I'll like your opinion on this also, hyperkalemia, especially when you're giving SGLT2, one of the other advantages is that these patients have less hyperkalemia when SGLT2 is on board. Have you noticed that as well? And I think that's part of now clinical guidelines also, that adding an SGLT2 does, in a sense, prevent some episodes of hyperkalemia, which you see. Again, hypotension is something, again, a lot of these drugs will reduce the blood pressure and sometimes renal function decline. I think very importantly, when you're starting RAS blockade and SGLT2 together early on, there could be slightly increase of creatinine or slightly drop in EGFR initially. So be careful. And again, your patients need to be counseled about that. Otherwise, they'll stop one of the drugs. Even I've seen nephrologists stop some of these drugs, which probably is wrong. So I think that should be kept in mind also. So your, again, important caveats in terms of monitoring these patients when you're seeing them.
So rather than, you should expect some creatinine rise, and that is going to happen.
Yes.
And if at all the creatinine is rising, it just tells that you need to monitor that patient frequently.
Correct.
It does not mean that you need to stop the medicine. And always try to look at the contributory factors of creatinine rise. So If I am giving ARNI and creatinine is increasing, first thing I would like to see if patient is dry, then
Hmm.
probably I would stop diuretic or I would reduce diuretic rather than stopping ARNI because
Hmm.
that is going to create impact on patient's long-term management. Also, when you are giving ARNI, always inform patients that which painkillers are safe for this patient
Hmm.
because many times we've seen diabetic patients, some borderline
Hmm.
nephropathy, given
Hmm.
ARNI, doing well, but then they go to some orthopedician for
Hmm.
pain.
Hmm. Hmm.
They have prescribed some NSAIDs and then they come with creatinine increasing and
Hmm.
developing acute renal failure. So
Hmm.
that information has to be given that which drugs are safe with this medicines and volume
Yeah.
depletion stage this drug should be withheld that because many times patients will end up with acute renal failure because they had diarrheal episode and they
Hmm.
continued ARNI. So this education is also very important in managing and preventing these patients coming repeatedly to hospitals.
Great. So I think all great points. And again, I think that's something we should be all keeping in mind while dealing with these patients on a regular basis. Okay, I think we can then go to some take-home messages from. Let me then begin with what I learned from you today in today's session. I think some very important points. I think one is, and I think this is a repeated theme which you said, especially diuretics. When you see a patient, look at whether the patient's diuretic indication is still there or not. The patient continues to be on diet, absolutely essential for initial management, especially if the patient is volume overloaded and patient is decompensated and patient is symptomatic. But then again, over a period of time, whether the drug needs to be continued or not, and then whether that drug interferes with other goal-directed medical therapy is something which should be well taken into account. I think again, looking at triggers. So again, patients with heart failure, there could be an underlying hidden trigger which could have led to the decompensation, which again needs to be looked at, diagnosed, treated to help the patient in terms of the heart management as well. So I think these are important points. Another interesting thing which you gave a very good clarification as far as beta blockers is concerned, the other drugs, important role of devices, especially ICDs and CRTs and in inappropriate indications. And so yeah, so all great points. Any other take-home message, sir, would you like to add? And we'll take a couple of questions from the audience, but any other take-home message from your end?
So the take-home message would be to not miss an opportunity to prescribe a guideline-directed medical treatment, not give overemphasis on the medicine which was just given for the symptomatic benefit, and also start very slow when you are prescribing the medicine.
Hmm.
Just look at the adverse effects of these drugs in the initial part. And let me tell you, once you have taken care of these patients in initial part, you don't have to look these side effects very frequently to this
Hmm.
patient. So
Right.
you just have to do this exercise when you're prescribing this drug, educate them what things to be avoided. Don't emphasize too much on things like fluid management. I've seen patient coming with small bottle in their pockets that I just count this water because if there is a thirst, that means body is requiring water. You
Right.
reduce, you put them on fluid restriction when they are congested, when they are
Right.
decompensated. But
Correct.
then you just allow them to take enough water, and it is mainly for end stage heart failure where even
Hmm.
minimal amount of fluid overloading
Hmm.
lead to
Hmm.
decompensation. So
Right.
this is not the rule, but we have seen that this advice of restricting fluid is given to patient who had just reduced ejection fraction and no heart
Hmm.
failure.
Hmm.
Patient is absolutely in asymptomatic or NYHA class 1 heart failure, and they are given advice of restricting fluid 1.5 because he had reduced ejection fraction. So these things are very important because this is again make them present with more side effect of very
Hmm.
important drugs.
Yeah.
Go slowly, try to achieve the optimal dose. I don't say that you always try to look at the dose that were given in trials, but for that particular patient, whatever dose is achievable, that should be achieved. And yes, there are devices, there are drugs, and devices should be also looked at fifth or sixth pillar in appropriate candidates.
Absolutely.
Yeah.
Okay, so I think we have one very interesting question from the audience. Which drugs can worsen heart failure? Which are the drugs we need to avoid in these group of patients? I think one group, again, from an endocrinologist perspective, pioglitazone, have a patient with heart failure, pioglitazone or thiazolidine is a complete no-no. Any other drug which you say you would be a little bit wary, especially from a cardiology perspective? What are the drugs you'd avoid here?
Yes. So patients with reduced ejection fraction, usually anything that will, so suppose you are giving AC inhibitors, ARBs, and you are prescribing NSAIDs and producing some renal dysfunction, that is going to worsen the heart failure.
Right.
Combination, drug interaction usually leads to this. Otherwise, excessive afterload increasing medicines, like patient who has patient is having heart failure, blood pressure of 90, and you start giving midodrine and increasing blood pressure, that is again going to worsen their heart failure. So if they are blood pressure 90, then it means that probably you need to reduce the medicine given for heart failure rather than adding some drug which is going to increase their blood pressure. So these are the drugs which I think should be avoided.
Yeah. Okay. Great, sir. Great points. So from the audience, if anybody has a question, they want to raise their hand and ask to Dr. Niraj Yadav, I think that would be a good time to do this. Great point, sir. And I think, one great point, one more point, I think I really becomes a highlight of today's talk is that your view on SGLT2 that they improve the cardiac ionotropy without increasing the risk of arrhythmia, which is completely rare and paradoxical compared to what we have for a long time, what the therapies that we had. Again, anybody in the audience, if they have a question, if not, we'll hand it over back to our host today, to the Zydus people. Hand it over back to you for taking this forward. Yeah, we are Dr. Sonkar. Yes.
So, sir, any question from the audience?
No, there are no more questions. I think we can close the session. We're already over time a bit.
Okay, sir. So this was very insightful and very valuable thing that we learned from Dr. Neeraj, sir. Great session, sir, and you have given us so many insights. Sir, I just want to ask one question that most of the cardiologists they prefer empagliflozin 25 mg also for heart failure. For the guidelines, they say it is 10 mg was there in the clinical trials. But do you also give like 25 mg for heart failure, sir? Empagliflozin?
So if I want to manage their diabetes, I would probably give that dose.
So 25 milligram is not a cardiologist dose. So all the trials have been, but when you have a patient with an additional need for a better glycemic control, which and weight management, then 25 milligram becomes a more suitable.
So if I'm looking at diabetes, then probably I would give that dose. But usually I don't have that confusion because I have liberty of sending patients to doctor home.
Great. Yeah. So any more? Yeah.
Because most of the cardiologists they say ki we are using it in 25 mg in heart failure also. So there's a little controversial thing.
So the guidelines are
yes. So I usually give 10 milligram when patient is non-diabetic heart failure. So for heart failure purpose, it is 10 milligram.
Okay.
But yes, if somebody is diabetic and you are giving it for diabetes control also, I have no clarity on that 25 milligram would not work. So sometimes for diabetic and heart failure, you give 25.
Right.
Okay. Thank you, sir. Okay, so this was a very insightful session. Thank you so much, sir, Dr. Neeraj, sir. Thank you so much. And thank you, sir. It was very nice, sir, that we have carried this 4 series continuously of heart failure. And we have taken like a lot of insight about its pathophysiology, management, its anti-pro-BNP role, BNP role, and one of the very important thing, insulin resistance that we talked in our pathophysiological thing. So this was very great. And we would love to have more of the interactive sessions like this from the cardiologist perspective as well as from endocrinologist perspective. So thank you so much. And I thank all the audiences who have taken their time for this interactive session. And it's okay. Thank you so much, sir. We'll end up this session.
Yeah, so I think thank you. And I think to all of you audience who were kind enough to join us for the last part, I think thank you so much for being part of this journey. I think it's a 4-part series. You can, if you missed something, go back and view. I think it's been a complete masterclass from all our 4 cardiologists who have been very gracious in the part of it. Finally, thank you, Dr. Niraj Yadav, sir, for being part of this. I think this was again probably the most comprehensive conclusion to the entire series. I think we covered everything. I don't think there's more to know about heart failure than what we learned today. So I think, yeah, that's about it. So thank you so much for being part of this, and I'll see you soon. And thank you to the audience, and good night, everyone. And thank you. Bye.
Good night.
Okay, good night, sir. Good night, everyone.